In humans, the disease primarily affects the cooler parts of the body, especially the skin and superficial nerves. Other relatively cooler parts of the body, including the upper respiratory tract, anterior segments of the eyes, and testes, can also be affected. The immunological state and immune response of the infected person determine the type of leprosy disease that develops. M. leprae is an intracellular bacteria, and the body responds through the cell-mediated immune system. When immunity is high, the invading bacilli are engulfed and destroyed without evidence of clinical infection. With a lesser degree of resistance, the organisms provoke a brisk lymphocytic response with aggregation of epithelial and giant cells, forming granulomas. When the cell-mediated immune response is grossly deficient, there is no lymphatic infiltration. Macrophages become distended with dividing bacilli and are unable to destroy them, and the bacilli are soon disseminated throughout the body. This slide shows a complicated but important diagram for understanding the spectrum of disease. After infection, if disease develops, it usually starts as indeterminate leprosy, with one or more hypopigmented or erythematous areas of the skin and a few acid-fast bacilli. Over months or years, these lesions may either disappear completely or develop into one of the recognizable types of leprosy, listed below the red dotted line on the figure. Leprosy represents a spectrum of disease, ranging from tuberculose disease, TT, on the left hand of the diagram, and leprotomous disease, LL, on the right. On the left, tuberculose leprosy is found in patients with a robust immune response and very few organisms. These patients may have only 1 to 3 lesions with central hypopigmentation and hypoesthesia. As shown on the right, lepromatous leprosy is found in patients with a weaker immune response and a higher organism burden. These patients have numerous poorly demarcated raised or nodule lesions on all parts of the body. As we move from left to right on the diagram, cell-mediated immunity, CMI on the figure, decreases, and the number of acid-fast bacilli in the dermis, AFB on the figure, increases. Most patients fall in between these two poles and are classified borderline tuberculose, BT, mid-borderline, BB, or borderline leprotomous, BL, and are considered to have unstable disease. At the bottom of the diagram is the WHO classification, designed for use in areas with limited clinical or laboratory expertise. It is based simply on the number of skin lesions. Paucibacillary, PB, leprosy is defined as 5 or fewer skin lesions without detectable bacilli on skin smears. Multibacillary, MB, leprosy is defined as 6 or more lesions and may be skin smear positive. Biopsies look different in the leprosy spectrum as well. On the left, tuberculoid TT leprosy is characterized by the presence of non-necrotizing granulomas in the dermis and peripheral nerves with absent or few acid-fast bacilli. On the right, leprotomous LL leprosy is characterized by the presence of sheets of foamy macrophages in the dermis and other sites containing numerous acid-fast bacilli, shown in red coloring, and absence of granulomas. The diagnosis of fully developed leprosy seldom presents difficulty, but by then the disease has been present for some years. On the other hand, the vague macules of early leprotomous disease are easily missed. Pure neural forms are often misdiagnosed even in endemic areas. Leprosy should be suspected in any person who has spent time in the tropics and who has developed a persistent, painless, non-irritating skin lesion or a nerve palsy. Skin smears with Ziehl-Neelsen staining are done in order to find acid-fast bacilli. However, the most accurate way to diagnose leprosy is a tissue biopsy, usually from a lesion. Confirmation of a pure neural leprosy is based on a biopsy taken from a thickened sensory nerve branch. Lepromin test, shown on this slide, provides a measurement of the level of cell-mediated immunity to M. leprae. The antigen is a biologically standardized suspension of killed M. leprae, which is injected intradermally into the flexor aspect of the arm. When positive, a granulomatous nodule develops after 4 weeks. This reaction is positive in 95% of healthy people and in those with a paucibacillary leprosy, but negative in those with multibacillary leprosy. Therefore, it is a prognostic rather than diagnostic test and is rarely performed in current practice. In patients with tuberculoid leprosy, TT, skin smears and nasal scrapings may be negative for acid-fast bacilli. A biopsy will reveal non-caseating granulomas bordering the epidermis, and the Leprmin test will be strongly positive. In patients with leprotomous leprosy, LL, skin smears and nasal scrapings will reveal plentiful M. leprae. The biopsy will contain loose granulomas composed of macrophages distended with acid-fast organisms, but the immediate subepidermal zone will be spared, and the Leprmin test will be negative. The findings in borderline leprosy will be less definite. The development of new diagnostic tests is a leprosy research priority. A test that could diagnose leprosy at a much earlier stage would mean that treatment could begin earlier, resulting in less disability and less transmission to contacts.